afternoon, everyone, and welcome to today's Public Health Ontario Rounds. Today's presentation is titled The Impacts of Alcohol Container Labels, a Systematic Review, and as part 3 of 5 of a larger series we've organized on alcohol risk and policy. If you've missed the earlier recordings, they're just becoming available, starting with our first session that will be available later on today. My name is Brendan Smith. I'm a scientist in health promotion, chronic disease, and injury prevention at Public Health Ontario, and I have the pleasure to moderate today's session. Before we start, I want to start with a land acknowledgement. We wish to acknowledge this land on which Public Health Ontario operates. For thousands of years, it has been the traditional land of the Huron-Wendat, Seneca, Métis, Haudenosaunee, and Anishinaabe, specifically the Mississaugas of the Credit. Today, this meeting place is still home to many Indigenous people from across Turtle Island, and we are grateful to have the opportunity to work on this land. Before we begin, I will mention a few housekeeping items. The chat pod has been disabled to limit any distractions during the presentation. Please use the Q&A pod if you have any questions during the session. A discussion and question period will follow the presentation. And if at any point during the session you experience any technical issues, please email capacitybuilding@ohpp.ca. I would like to state that as the moderator of the session, I do not have any conflicts of interest. It is now my pleasure to introduce the speakers for today's presentation, Drs. Aaron Hoban and Alex Zuckerman. Aaron Hoban is a senior scientist in the health promotion, chronic disease, and injury prevention portfolio at Public Health Ontario. She holds an appointment as an associate professor, status only, in the epidemiology division at the Dahlonega School of Public Health. Alex Zuckerman has a PhD in biomedical sciences and a master's of science in global health policy. Currently, she is a research analyst, systematic review lead, and guideline methodologist in evidence synthesis and knowledge translation unit at the Public Health Agency of Canada. So at this point, I'd like to pass it off to Aaron to begin the presentation.
Great, thanks, Brendan, and thanks everyone for joining us today. So we are going to be sharing some of our work from a systematic review examining the impact of alcohol labeling on behavior, knowledge, and support. This work was submitted to Lancet Public Health, and we received a revised and resubmit, and it is now back under review at Lancet Public Health. Next slide, please. As Brendan mentioned, this is the 4th rounds in a PHO Rounds series called Alcohol Risk and Policy. I just wanted to mention that the 5th and final round will be held on May 14th and will focus on minimum legal drinking age, and our presenter will be Dr. Jürgen Rien. Next slide, please. Before we start, I do have some declarations to make. I have participated as a member on advisory panels focused on developing guidance and reports for provincial, national, and international work focused on alcohol policy and specifically alcohol labeling. Next slide, please. Although Alex and I are presenting this work today, I do want to acknowledge the systematic review team at the Public Health Agency of Canada and all of their contributions to this work, as well as 2 of our colleagues who contributed as subject matter experts, Norman Giesbrecht from CAMH and Tim Stockwell from the Canadian Institute for Substance Use Research at the University of Victoria, as well as the support from the Health Canada Library and our research and library staff here at Public Health Ontario. Next slide, please. By the end of this event, participants will be able to understand the state of the evidence investigating the impacts of alcohol container labels. We'll be able to identify limitations and gaps in the evidence requiring further research and be aware of alcohol container label policies, practices, and opportunities in Canada and internationally. Next slide, please. The first few slides, I'm going to just try and set the Canadian context for this work. So Canada is a high alcohol consuming country. In 2019, Canada consumed almost 10 liters of pure alcohol per capita among those ages 15 and older, which is approximately 4 liters more than the world average. And Canada is ranked 40th out of WHO member states. Next slide, please. The Global Burden of Disease study estimates that among the risk factors that they measure, that Canada is the 6th leading risk factor driving the most death and disability combined. And alcohol was ranked 6th in 2009 and again in 2019. Next slide. The Global Burden of Disease study team estimated that in 2020, 7,000 new cancer cases attributable to alcohol in Canada, and about 25% of these new cancer cases attributable to alcohol were female breast cancer cases. So in 2020, the costs of alcohol in Canada were 19.7 billion. Alcohol contributed to a greater health burden and societal cost than any other substance, including tobacco and opioids. Next slide, please. Given the, despite the high health burden and economic cost of alcohol in Canada, public awareness of alcohol-related health risks is low. So our team at Public Health Ontario conducted a study among 2,000 adult consumers in Ontario in 2014, and we asked study participants if they were aware that alcohol can cause a range of different health conditions. And on the low end, 20% of study participants said that they were aware that alcohol can cause breast cancer. And at the high end, 92% of participants said that they're aware that alcohol can cause harm to an unborn baby and liver cirrhosis. You could just click it again, Alex. We conducted a national survey with 5,000 adult alcohol consumers in March and April 2023. So just after Canada's updated guidance on alcohol and health was released and it was in the media. And we asked folks if they were aware that alcohol can cause at least 7 different types of cancer. And 29% of the consumers participating in our study said that they were aware of this. And 50% said that this information makes them think about drinking less. Next slide. So why is public awareness of alcohol-related health risks low in Canada, including, serious health risks like cancer? And some experts suggest that the reason might be that the alcohol information environment is dominated by the alcohol industry. So society is constantly exposed to cues that alcohol is that's sort of strengthened the impression that alcohol is acceptable in many different social contexts. So whether you're commuting to work or going grocery shopping or starting school as a freshman in university or college, getting a haircut, or even being a mom. Next slide, please. Why are alcohol container labels an option to consider? Alcohol container labels are a unique information-based intervention in that consumers are exposed to key health information and advice repeatedly at critical points of contact. So at the point of purchase and the point of consumption or pour, essentially anytime the consumer is handling the container. Labels are appealing because of their low cost to regulators, the unparalleled reach among consumers, and higher exposure among high volume consumers because theoretically they're handling the container more often. Next slide, please. A large, well-established evidence base indicates brightly colored tobacco warning labels that are large in size with large font, images, and clear health messages can increase consumer knowledge of health risks, shift societal perceptions of product risks, and even change population level behaviors. Canada is a world leader in designing strong health warning labels for tobacco and most recently cannabis, but alcohol is largely exempt from these regulations. And the one aim of this slide is to provide a visual exercise contrasting the packaging packaging and labeling on cigarette packages and cannabis packaging in Canada compared to alcohol containers that are sold in Canada. Next slide. In Canada, alcohol containing 1.1% or more of alcohol by volume must show an alcohol by volume declaration on the principal panel of the container. And this regulation is national, so applies to all 13 provinces and territories. Yukon and Northwest Territories have additional directives that require warning labels be applied to containers as they're being stocked on shelves in government liquor stores. Next slide, please. About 66 countries have mandated alcohol, health, and safety labels on containers. These labels vary widely in terms of label message and format. Most include a text-only general health warning or icon to caution about drinking when pregnant or when driving. The US mandated this health warning label on all alcohol containers starting in 1988, and it is the only mandated label to largely be evaluated in real-world experiments. Next slide, please. More recently, so in 2018, Ireland passed the Public Health Alcohol Act, which included a package of alcohol policies affecting the price, advertising, and labeling of alcohol products. It is important to note that the Ireland label took 5 years to implement after being passed due to strong industry opposition. Now, Ireland will be the first country globally to require a health warning label with a cancer message on all alcohol containers. There are other countries that have a warning label as an option to be put on alcohol containers in their legislation, but Ireland will require this label on all alcohol containers and is the first country to do that. And this will start as of May 2026. Next slide, please. There have been a lot of challenges for Ireland as well as other countries who have tried to implement mandatory health warning labels or alcohol container labels. And their experiences were recently captured in a New York Times piece shown on the slide here. The main arguments for the challenges from industry for mandatory alcohol container labels are generally economic, sometimes trade barriers. And one of their main arguments is that they argue that alcohol labels are low value and are not effective for supporting consumers in making informed decisions or for affecting behavior. Next slide, please. So given the uncertainty of the impact of alcohol container labels, there have been 6 previous evidence reviews that have been published in the literature, including 3 systematic reviews, 2 rapid reviews, and 1 scoping review. However, all 6 of these evidence reviews do have limitations. So for example, 1 did apply grade, but in the end only included 2 alcohol container label studies in their final set of records. So this systematic review also looked at health warnings on food products in addition to alcohol products. The other 5 reviews did not define a comparison or control, did not use a comprehensive search. For example, the date of the search could have been limited, or the review was limited to only 1 label type, so health warnings, for example. And the other reviews did not analyze the label impacts by population subgroups. Next slide, please. So the objective of our systematic review was to provide a high quality, comprehensive, transparent, and up-to-date review to establish the effect of 3 types of alcohol container labels. So health warning labels, standard drink labels, which means the number of standard drinks in a container, national alcohol guidance information labels, or a mix of any of these messages on a label. And we looked at the impact of these labels on 3 policy relevant outcomes. So alcohol use related behavior, knowledge of label messages, and support for alcohol labeling. Next slide, please. And I'll pass it over to Alex to talk about the methods and results.
Thanks so much, Erin. So I'm going to start us off in the methods by talking about how we selected the outcomes that we included in a systematic review. We did this in consultation with policy stakeholders and subject matter experts, and we developed a causal pathway to really understand the different outcomes that are reported in the literature. And the causal pathway starts here on the left-hand side with the intervention or exposure with alcohol container labels. And then you sort of get to the very first outcomes that are most directly related to the interaction with the alcohol container label. So participants might notice the label, then pay attention to it, and then ideally be able to recall it later. They might ideally also understand it or process it, which in this case means thinking about the label, talking about the label with others. There are a number of facilitating factors that can influence these steps. So, for instance, how noticeable the label is, whether it's very colorful or very big, whether it's perceived to be credible, and whether the participant has any effective reaction. So, if they feel positively or negatively about the label. Most of the literature reports on outcomes that are either, early on in the causal pathway here, or that are these facilitating factors. So that's really the bulk of the available evidence. However, what we were interested in and what we decided to focus on are three key outcomes, as Erin's already mentioned: knowledge of the label message, and then consumption and related behavior. So, not just drinking alcohol, but for instance, whether or not you drink alcohol before driving. And finally, support for alcohol container labels. And these obviously interact. You need to have an understanding that alcohol is a risk when you're driving to be able to make the decision of whether or not you want to drink before you drive. And so these three key outcomes, any studies reporting on those, we termed to be direct evidence, and everything else was indirect evidence, and we didn't focus on it for this systematic review. For our overall approach, we really adhered to best practice methodology according to international standards. We started with a literature identification with a comprehensive search of 5 databases. The initial search was in September 2021, and we performed 2 updates, the most recent in March 2024. We also supplemented these database searches with a hand search of reference lists and looking for reputable grey literature, for instance, from provincial or national governments. And this hand search was carried out in 21 and again in 2024. Once we had identified our literature, we performed screening and data extraction. And here each step was completed by 2 reviewers independently. Something to note is that for the initial search for relevance screening, which looks only at the title and the abstract of a potentially relevant study, was done by 2 humans. However, for the later updates, due to resource constraints, this was done by 1 human and machine learning that is built into the platform we were using. And this machine learning process was actually trained on the first selection process that we did. So we generated a classifier based on the decisions made by 2 humans. And then for the updates, 1 human co-screened the references with the machine learning process. And we found that actually this process was about as accurate as a human reviewer. 2 things to note. One, this affected less than 10% of the references that we actually screened. And 2, the level 1 screening, so the looking at title and abstract, is set to be over-inclusive. So it was sufficient if 1 reviewer, human or machine learning process, decided that a reference was relevant for it to then move on to full text screening. Finally, with full text screening, once we determined whether a study was eligible and discovered whether it was reporting on any of our relevant key outcomes, we extracted the data for those outcomes. And this was done sequentially. So 1 reviewer extracted the data and a second reviewer validated it. We then assessed each study for risk of bias using rigorous assessment tools, ROB2, Robbins I, Robbins E, and the JBI tool for prevalence studies, depending on the study type. And where we later on report on low risk of bias, this would indicate that we believe that the data reported is close to the true treatment effect. Finally, we synthesized all the different data for each outcome into impact statements and assessed these for certainty in the evidence with GRADE. And you see the abbreviation spelled out at the bottom of the slide there if you're unfamiliar. And where we report a high certainty in the evidence, this would suggest that we believe that the evidence is close to the true effect. We also performed a sensitivity analysis where we synthesized only studies that were at low or moderate risk of bias and looked at whether there were any differences to be found between those two outcomes. Now, let's get into the meat of things, the results. I'm going to talk about three broad sections here. First, I'm going to start with the evidence availability in terms of our search, what we found. Then we're going to get into the experimental data. So here we are looking at the impact statements that we generated for each outcome, separated by label type. And these are all data, and this is all evidence that we assessed with GRADE. And then finally, I'm going to talk a little bit about subgroup data. And here we looked at two subgroups that we deemed to be most relevant. Subgroups that were defined by alcohol use level, so abstinence, drinking, binge drinking, etc., or health literacy, for which we also allowed education status as a proxy measure. And here we summarize the data narratively, and so we couldn't assess them with GRADE. We didn't have enough evidence to go through the GRADE process for the subgroup data, unfortunately. In terms of available evidence, you have the PRISMA flowchart on the right here, and you can see that for relevant screening, we had just under 3,000 references in total to screen, which obviously dropped off sharply as we went through, and we ended up with 40 relevant studies. Something I do want to draw your attention to is that in terms of relevance of the study itself, so whether it looked at alcohol container labels having an effect on an outcome, we actually had 118 studies, but 78 of those didn't report on any of our relevant key outcomes, which brings us back to what I mentioned earlier, which is that most of the evidence base looks at early causal pathway outcomes or facilitating factors. We found in the literature that there is substantial heterogeneity, and that was really in anything you can think of: label design, intervention design, outcome measurement, outcome definition, across the board, really, really broad range of approaches and definitions. Unfortunately, most of the randomized control trials that we found, which are obviously usually the gold standard, were poorly designed for our purposes. And what I mean by this is that they looked at labels, for instance, as a one-off exposure, or participants interacted with labels only online, which is not really true to how you would encounter alcohol labels in the wild, in the liquor store every time you go to buy a bottle of beer. And finally, overall, the evidence base was unfortunately quite limited. Nevertheless, we found 40 studies. All of them were in English, although the review team also had capacity to assess studies in German, Spanish, and French. And most of them looked at health warning labels. Finally, the majority of them came from the States, although Canada was a close second. And the studies from the States mainly looked at the US federal label that Erin also showed on the slide earlier. Which brings us to one of the sources of heterogeneity in the literature, and I really just want to demonstrate the amount of variation that we saw in the health warning labels. In the top right there, you have the government warning that is federally mandated in the US. And as you saw on Erin's slide, really there are no restrictions on how this has to be implemented or designed. It can be horizontal, it can be tilted by 90 degrees, it can be in colors that match the branding. It's really not very noticeable. On the other hand, we have the three labels that Erin et al. Used for the Yukon and Northwest Territory studies, which are very bright contrasting colors. There is a clear cancer message, and you have the standard drink label and the low risk drinking guidance label, although it should be noted that that was based off the previous low risk drinking guidance, not the new guidance, Canada's guidance for alcohol and health that came out recently. I'm going to start off the discussion with the results that we assessed for certainty in the evidence and with health warning labels. And here what I've done to save us all from staring at very boring tables for a long time is put together these impact statements that are color-coded. So in the center here, you have the impact statement with the sample size and the number of studies and study types. And then on the left-hand side, you have color coding for the effect size, so how big the effect was from moderate moderate to large all the way down to uncertain. And the white uncertain box is there for when studies disagreed with each other in terms of effect size, to indicate that we can't say there wasn't a cohesive result. On the right-hand side, you have the certainty rating all the way from high certainty in pale green down to very low certainty in the white box. And very low certainty really means that we can't say either way what the effect is because the evidence quality just isn't high enough. And here are two examples with little to no difference of health warning labels and general consumption at the individual level and in alcohol impaired driving. Next, we had low certainty in 3 of the outcomes on this slide. We found that health warning labels may reduce consumption quantity or reduce it slightly. They may result in a large decrease in consumption rate, which in this case means speed of consumption or how quickly you drink the bottle, and that they may slightly reduce consumption during pregnancy. And finally, we were found very uncertain in the evidence of the effect of health warning labels on consumption frequency. Continuing to look at health warning labels, we found with moderate certainty that health warning labels may slightly increase the frequency of limiting alcohol consumption before driving, and that they may result in a moderate to large reduction in selecting the container that has the label applied to it. But also little to no difference in support for health warning labels. And then with low certainty, that health warning labels may result in little to no difference in the number of standard drinks purchased. And then a very interesting outcome that health warning labels may result in no increase to a very large increase in health risk knowledge. And if you think back to the slide showing the variation in label design, it becomes very apparent that differences in label design might impact how effective the labels are in imparting knowledge to the participants. For the remaining label types, we were able to synthesize impact statements for 2 outcomes each. Here, for standard drink labels, unfortunately, we found little to no effect for either of these outcomes in selection of beverages with higher alcohol content. So do people use standard drink labels to pick bottles that have more alcohol in them? And also no effect on support for standard drink labels. For the low-risk drinking guidance labels, we found with moderate certainty that they result in little to no difference in knowledge of drink limits for low risk to health, and with very low certainty that they may increase support for themselves, but here, unfortunately, the evidence wasn't certain enough for us to draw a conclusion. And finally, labels with multiple or comprehensive messages, we found with moderate certainty that these labels likely result in a large reduction in general consumption at the individual level, and with high certainty that they result in a large reduction in mean standard drinks sold per capita. To summarize, unfortunately, most of the impact statements were graded at low or very low certainty, although we did find 6 outcomes which suggested effects for health warning labels, 1 for low-risk drinking guidance labels, and 2 for the mixed or comprehensive labels. And here's a little summary grid to give us an overview. For health warning labels, we found moderate to large effects with moderate to low certainty, respectively, for selecting containers less often and slowing consumption rate or speed of consumption. And small effect for lowering consumption quantity, consuming less alcohol before driving, and consuming less alcohol during pregnancy. And then for the multiple and comprehensive labels, we found with moderate certainty that they decrease individual consumption, and with high certainty that they decrease the mean standard drinks sold per capita. The sensitivity analysis that we performed did not affect any of the outcomes for which we found effect sizes, so we're not going to go into detail here. Next, let's get into the subgroup analysis. Here again, we have color gradients, only 3 on each side this time. And now on the right-hand side, we've got the risk of bias. The pale green would indicate that all the studies that contributed to a particular narrative statement were at low risk of bias. The teal color that at least one study was at moderate risk of bias, and the blue color that at least one study was at high risk of bias. And immediately you can see that all the outcomes on this slide had at least one study contributing that was at high risk of bias. And here we're looking at participants who consume alcohol or consume more alcohol compared to those who don't consume or consume less. We did find effect sizes here for 3 outcomes, and we found that the effect of health warning labels on reducing alcohol consumption may be smaller in participants who consume more, that their effect on increasing knowledge of driving risks may be larger in participants who consume alcohol and drive, and that the support for health warning labels may be lower in participants who binge alcohol compared to those who do not. Continuing to look at participants based on alcohol status, we found that support for standard drink labels and low-risk drinking guidance labels may be lower in participants who use or binge alcohol, and that the effect of mixed labels on reducing alcohol consumption may be similar in participants who consume more compared to those who consume less. Moving on to subgroups defined by health literacy, and here we are looking at participants with low health literacy. Again, all narrative outcomes had at least one study contributing that was at high risk of bias, but we did find that support for health warning labels, standard drink labels, and low risk drinking guidance labels may be lower in participants with low health literacy. However, interestingly, the effect of mixed rotating or comprehensive labels on reducing alcohol consumption may be larger in participants with low literacy. In summary, for the subgroups, we found that participants who consume or consume more alcohol may be less likely to reduce consumption when exposed to health warning labels, and also may be less likely to support labeling with health warning, standard drink information, or low-risk drinking guidance. And participants with low or lower health literacy may be more likely to reduce consumption when exposed to mixed or comprehensive labels, but may be less likely to support labeling with health warnings, standard drinks information, or low-risk drinking guidance. Thank you, and I'll pass it back to Erin.
Thanks so much, Alex. So I am going to talk about 3 key takeaway messages from this work. The first, Alex did a really nice job emphasizing the limitations to the available literature, as well as the heterogeneity in the studies that are available and that were included in this review. In terms of, as Alex said, label design, outcome measures, and the population that was sampled in the study. So almost on every study characteristic, there was heterogeneity across the studies that were included in our final sample. Now, our most notable results from this review: first, health warning labels may affect certain consumption behaviors, reducing consumption during pregnancy, slowing consumption rate and quantity consumed per occasion, reducing alcohol drink selection, and limiting consumption prior to driving. And secondly, labels with the mixed or comprehensive messages, including a health warning, alcohol guidance, and standard drink information, likely result in substantial reductions in individual level alcohol consumption and per capita ethanol sold. And these 2 notable results are either different than the previously published reviews, or are slightly stronger statements than what was stated in the 6 previously published reviews. Next slide, please. So although we did apply Cochrane standards to this systematic review, there are some limitations that we wanted to note. So first, the heterogeneity of the evidence did make this task very complicated. And in order to synthesize the evidence, we did have to make a number of judgment calls that we were transparent about when writing up the results and the discussion of this paper, because we were very sensitive to the fact that some of the nuances of the studies may be obscured, and some of the differences may not have been exactly captured during the synthesis process, which definitely affected the results of this review. Also, too, as Alex had mentioned, there is a lack of evidence for the non-health warning label types. So the standard drink labels and the alcohol guidance labels, as well as the mix labels, there were fewer studies testing those types of labels in the literature, and there were also very few studies testing any sort of direct health outcomes, such as cancer, for example. And then finally, we wanted to highlight that there were limited real-world evidence in the included studies, which may limit applicability of results. So the real-world studies were, for the health warning labels, were largely the evaluations of the US health warning. There also was an evaluation of the France pregnancy icon, which is shown at the bottom of the slide there. And the real world evidence for the mixed label types was completely limited to the study in Yukon and Northwest Territories. And why this is important to note is because in previous reviews, as well as in our review, the results differed between the real world studies compared to the more experimental studies that were conducted online or in lab-based settings. Next slide, please. So given the results of this systematic review and the potential for alcohol container labels to influence individual level and population level alcohol consumption, the implications of this work is that there is an opportunity to strengthen alcohol container labels in Canada and internationally. The results of this review suggest that the scientific literature align with recommendations requiring labels with health warnings, alcohol guidance, and standard drink information that were called for in recent Canadian reports. So the 2023 guidance on alcohol and health, also the 2023 Ontario Chief Medical Officer of Health report called for these comprehensive alcohol labels on containers. And I also wanted to highlight that there is a bill calling for mandatory alcohol labels in Canada that has passed a second reading in the Senate that was put forward by Senator Brazeau. The results of this review also suggest public support for labels is generally high in Canada and internationally. And a few other factors to consider. We've mentioned many times that the labels that were tested in the studies included in this review varied considerably and affected the results. One label does not fit all. The label format and label message really matters. So depending on what the policy objective is for the labels, that really needs to be considered when deciding what the label format and message will include. Also, too, there are potential for subgroup differences in terms of label impacts. And so this needs to continue to be evaluated as labels are implemented around the world. And lastly, in addition to labels having the potential to influence alcohol consumption, I think it's also important to note that the literature found that as the public becomes more aware of alcohol-related health risks, particularly cancer, there was an association with stronger support for other types of alcohol control policies, such as pricing policies, restrictions on alcohol availability, and alcohol marketing. So those types of policies that have been shown in the literature to be very effective for reducing population level harms from alcohol, but are generally unpopular among the public and thus policymakers. So the idea here is, as the public becomes more informed of the health risks from alcohol through labels, for example, they may be less likely to push back as policymakers propose increasing the price of alcohol. Next slide, please. And I just wanted to end by identifying some of the gaps in the literature that we highlighted in our review. So first off, what is the optimal label design and message combination? for influencing, for supporting consumers and making more informed decisions, but also influencing their alcohol use behaviors. How does repeated exposure to labels influence label impact? So earlier I mentioned that there were differences in the outcomes of the studies depending on whether or not the study was conducted online or in a laboratory setting, where participants were exposed to the label once and very briefly, versus the real world studies where participants had the opportunity to potentially be exposed repeatedly to the labels. So how does this repeated exposure to labels perhaps better simulate a real world dose of labels and then better capture the impact of labels on consumer outcomes? Thirdly, can results of real world long-term label interventions be replicated? And then finally, do labels have differential effects on population subgroups? So Alex did a really nice job of summarizing the available literature looking at differential effects of labels by different levels of alcohol use as well as health literacy. So what other population subgroups may experience differential effects from labels, and perhaps some of the key demographics to examine this might be gender, age, etc. And I'm going to leave it there, and happy to take any questions.
Great. Thank you, Erin. We'll now move on to the Q&A segment of this event to address some of the questions from our audience. Please continue to enter your questions in the Q&A pod if you have not already had the opportunity to do so. And while just people get, there's one question that's already in the chat waiting for you, and that is, and this can go to either Alex or Erin. Why is alcohol exempt for health warning labels?
Sure, I'll take a stab at this one. I think possibly one of the reasons is because alcohol is normalized, like the extent to which alcohol is accepted and normalized in Canadian society. So almost 80% of adults in Canada use alcohol each year. It's available and you know, quite often a big part of celebrations, whether that's birthdays or weddings or anniversaries. And so because I think it's been normalized in society to that extent and for so long and hasn't had any health warning labels on the container, it's more difficult now to suggest that health warning labels should be on alcohol containers compared to, let's say, cannabis, which is a newly regulated product. And when it was first regulated, there was a health warning label on the package. So it was easier to sort of start at that standard versus to retroactively consider putting health warning labels on a very well-established product in the country. I also wonder too if it's because society is generally unaware of the serious health effects caused by alcohol. So when we have talked to consumers in some of the focus groups, other than, you know, a hangover or potentially alcohol use disorder, folks are generally unaware of the 230 negative health conditions caused by alcohol. So I think that as the population becomes more aware of the substantial harms caused by alcohol, they'll be more open to, you know, alcohol isn't an ordinary commodity. It actually does deserve special status that include health warning labels and perhaps some other control measures.
I agree with Erin on all the points. And I think I would also like to add that a lot of people aren't necessarily aware of how much they drink, and also how their level of drinking relates to risk for them personally. I think there are a lot of studies out there, or the studies that look at personal risk estimation. People tend to underestimate both how much they drink and how risky that is as well. So there really is just not a lot of awareness around personal effects that alcohol consumption might have.
Okay, thank you. There's two attendees who are wondering about how you assess people's level of health literacy in your systematic review.
So Erin, do you want to start with the health literacy in particular, because you used the measure for the Yukon study?
Yes, I'm trying to think of the name, the new vital sign tool that has been validated for assessing health literacy was incorporated into the labeling study in Yukon. And that was actually at the request of the government in Yukon. They were very interested to see if the labels had different effects by health literacy level. So we use that new vital sign tool in that study.
That is the standard tool that was also used in the other studies that directly assessed health literacy. Where we looked at education status, we generally equated participants who hadn't completed high school with that level of low health literacy. And depending on how the authors defined the different education statuses, that might have also included participants who only who did finish high school but didn't go on further. But I do believe that the vast majority of studies where we used education status, it would have been participants who didn't complete high school.
Okay, thank you. Another question's come in. This one, could you explain more if the review found that health warning labels are strongly associated with an increased awareness of the health impacts?
So interesting. Something to point out is that often in the literature, awareness and knowledge are used interchangeably. The way we assessed knowledge was very specific. We didn't include any outcomes where participants were prompted with the label. So if, for instance, a question asked, do you remember this label? The label that said alcohol causes cancer, how do you feel about that? We wouldn't have included that because we said that knowledge is something that has to be present for you day to day, not just when you're reminded of it. So, for instance, most of us know that we shouldn't drink and drive. It's not something we have to be reminded of. And that's the approach that we took for knowledge. And so we didn't actually look at awareness. We grouped in awareness with the earlier causal pathway outcomes because awareness would have been a prompted outcome. The way that knowledge was assessed differed between studies. Some of them asked broad questions about health risks, for instance. So if the label said alcohol causes cancer, participants might have been asked to list the health risks of alcohol. And if they named cancer, they were judged to have knowledge of that label. And again, here there was a huge amount of heterogeneity between the studies, between how these outcomes were defined, but we really did our best to only synthesize evidence that was roughly equivalent.
If I could just make a quick addition to Alex's response. We were surprised in the result that the label's impact on knowledge was mixed. And so we really dug into that outcome and those studies that were informing that outcome. And a large number of the studies were assessing knowledge of pregnancy warnings. And if you can remember at the start of the presentation, I showed that when we asked alcohol consumers in Ontario if they knew that alcohol can cause harm to an unborn baby, 92% of consumers said that they knew or believed this. So it is quite high. A large percentage of the population are aware of this, whether they're exposed to labels or not. So they're might not be a lot of room for improvement. And then when you're comparing the group that's exposed to a pregnancy warning versus the group that's not exposed to the pregnancy warning, perhaps the change in knowledge isn't great enough to exceed a significance threshold. So that was one of the things that we had to unpack and talk about in the discussion of this systematic review to potentially provide some context around this result.
Yeah, and this is also where we get into the facilitating factors with relevance. If you are not somebody who can become pregnant, you might not see any point in retaining that information because it's not directly applicable to you. So that's where the label message really matters as well.
That's a great point, Alex. And one of the slight revisions that the WHO has made on their recommendations for labels is to think about mandating label messages that can apply to the entire population, and where a large proportion of the population can't exclude themselves. So pregnancy is a great example where that might only affect a small proportion of the population. So include or consider including some label messages that will affect the full population.
Okay, that's a really nice segue into a couple of questions, if I can try and summarize them from the chat. Really interesting questions, so keep them coming in. But it's basically around the design elements. So which of the design elements were common among the studies showing impacts on the knowledge and/or alcohol use?
Erin, do you want to take that one, or shall I?
You go first.
Okay. So again, bear in mind that it's very, very difficult to pick out what is specific to the label elements here, because the studies were very varied in terms of their intervention design, exposure. So I would say that it not only matters what the label looks like, it matters how you interact with it. Is it in the real world? Is it on a computer screen? Do you only see it once, or do you see it multiple times? And in fact, in the studies that we looked at, what seemed to matter almost as much as how often you were exposed to the label. Because if you only ever see it once and then you have a follow-up question 8 days later, you're not necessarily likely to recall that. What mattered a lot is noticeability. If you don't notice the label on the bottle, there's no way for you to gain knowledge of what it says. And then again, we're getting into personal relevance. We're getting into how clear the message is, whether it's anything that you can concretely remember. The US federal label talks about general health risks. The label that Erin and the colleagues used in the Yukon very clearly says alcohol causes cancer. So how clear the message is, how specific, how relevant, how noticeable, I think these are some of the elements that I would point out.
Anything to add, Aaron, before we move on?
No, I mean, I think Alex did a really nice job. The labels that we tested in the Yukon labeling study, we did a number of smaller studies to inform the label format and messages included on those labels. And on the slide that Alex showed the different types of labels, you may have noticed that the labels tested in Yukon, more than the other labels on the slide, resembled warning labels on tobacco packages. So in terms of the color and the use of bold font and the very clear types of messages, even we used icons on the alcohol guidance label. And that's because the tobacco literature is much larger and well established. So some of those design elements have been studied quite closely on tobacco warning labels and which ones are most effective. And so we borrowed from some of the tobacco literature when we were designing the Yukon labels. And then in this review, as Alex mentioned, there were a number of different types of label formats and messages that were tested. And the ones that, had a clear and simple message about a health risk, particularly cancer versus a pregnancy warning, or that included the label where it was very distinct on the container and not lost in the container design. That seemed to be more effective. So those sort of simple design, label design principles are likely very important in terms of how effective the label is.
Okay, and I'll try and work through a few more questions. One is, did you try to apply a quantitative meta-analysis to any of the outcomes?
We originally had envisioned doing a meta-analysis, but unfortunately, there was too much heterogeneity. It just wasn't feasible. And we already had to make, as Aaron mentioned earlier, a number of judgment calls. We obviously had to synthesize across some differences in the studies, all of which are reported and discussed in the manuscript. And we really felt that doing a meta-analysis was not really liable to add anything. On the contrary, it was liable to to obscure differences, we might have ended up with a null result purely for reasons of heterogeneity. And so in the end, it wasn't deemed to be feasible. We did consult with a statistical analysis expert on it as well, and everybody agreed that for usefulness, and we really wanted to produce a manuscript that would inform further research and that could be used in further discussions on the topic, it would make more sense to synthesize impact statements according to grade guidance where meta-analysis isn't possible. We also followed SWIM guidelines, so synthesis without meta-analysis guidelines, to make sure that our review was still the highest possible quality even without the meta-analysis element.
Okay, and then one question I know is very important for our audience today is what specific actions can public health units across Ontario do to support the progression of alcohol warning labels?
Please go ahead, Erin.
I know that, or I am aware of some of the activity that public health units in Ontario have already participated in. So advocating for labels to the federal government to be implemented at the federal level, participating in different discussions like today, providing feedback on some of the studies that Public Health Ontario has taken the lead on related to alcohol policy and alcohol labels. I think in that perhaps for the time being, in the absence of labels at the local level, public health units could potentially think about public education campaigns, informing consumers in their communities about the serious health risks from consumers, because I am quite convinced that as the public becomes more aware that alcohol isn't, just this ordinary benign substance, that there actually are serious health risks to consider when using alcohol, that they will be more likely to get behind these efforts to disseminate the message that alcohol causes harms and we need to rethink it as a society, how we're using it, where it's available, and how it's promoted.
I do want to add that obviously with the systematic review, we are not providing recommendations. We're really just looking at the evidence and synthesizing and assessing it. And as Erin said, there is more, lots of research gaps that could still be filled, looking at label design, all of these things. And then there are other questions that are way beyond the scope of a systematic review, how feasible it is, how acceptable it is, the costs associated, all of these other considerations. So really with the systematic review, we're hoping to provide a good amount of synthesized evidence for people to have these onward discussions.
Okay, thank you very much. What an interesting conversation today. And if you have any additional questions, I see that there's some additional questions we didn't get to. You can follow up with either Erin or Alex. I'm sure they would love to hear from you. As we wrap up today's PHO rounds, I'd like to thank both Erin and Alex for presenting, and I would like to thank everyone who joined us today for the webinar. You can expect to receive a brief and anonymous PHO round survey for today's session, so please try to complete this to help us improve our programming. Lastly, to access past PHO presentations, and I mentioned some of this alcohol series are now starting to be posted, and to view confirmed and upcoming sessions, please visit the PHO website, head to the education and events, and click on presentations. So thank you very much for joining us again, and hope everyone has a wonderful day.